Hi, welcome to What's Happening at Tri-City Medical Center. With us is Dr. David Cohen, a cardiac electrophysiologist at Tri-City Medical Center, specializing in treating heart rhythm disorders, also known as arrhythmias. Welcome, Dr. Cohen. Let's start by answering the question, what is catheter ablation?
So catheter ablation is probably one of the most interesting aspects of my work. It involves mapping out the arrhythmias that a patient might have. The first part of a catheter ablation is coming to the diagnosis typically, and by doing that is we advance electrode catheters through the veins in the leg up into the inner chambers of the heart, and we can diagnose an ongoing arrhythmia, or we can actually stimulate the arrhythmia and determine exactly, pinpoint where it is. And then by applying heat energy to the focal area of the arrhythmia, we can terminate it or cure it. If it's a specific arrhythmia called SVT or supraventricular tachycardia. Other arrhythmias involve more extensive ablation, such as atrial fibrillation, and that involves going into the trigger sites for it, which are the pulmonary veins, and blocking those triggers. But the general idea of catheter ablation is a minimally invasive technology to cure or control arrhythmias. And patients typically go home the same day. There are no incisions, and they return to their normal quality of life within days.
So it's a combination diagnostic and treatment tool.
Exactly, yeah. If the patient comes in and the diagnosis is uncertain, we can typically come to a diagnosis that day at the same time that we're going to cure it.
Why is there a special focus on detecting and treating atrial fibrillation?
So atrial fibrillation is the most common arrhythmia, and it's becoming more and more common as the population ages, and as the typical risk factors such as hypertension, obstructive sleep apnea, obesity are more prevalent. It's important to diagnose and treat it appropriately because atrial fibrillation can increase the risk of stroke. During atrial fibrillation, the upper chambers of the heart, they quiver, and a clot can form, and if you're not appropriately anticoagulated or your blood isn't thinned and you're at one of these high-risk subgroups, then a clot can form and it can cause a stroke. Fortunately, our modalities to diagnose atrial fibrillation have improved significantly, whether it be with long-term rhythm monitors that are external to the chest, or implantable loop recorders, which are small subcutaneous monitors underneath the chest, under the skin. And then treatment for atrial fibrillation has also gotten much better, safer, and faster. So at Tri-City, we are the only hospital in the northern San Diego region that has the new cryoballoon ablation technology, which uses a balloon-based freezing technology to isolate those triggers, those pulmonary veins that triggers that lead to atrial fibrillation.
What are some of the other technologies used at Tri-City Medical Center in your field?
Besides the new cryoballoon technology, which it has been very promising and effective for atrial fibrillation patients, we have a implantable loop recorder, which is like a 24/7 continuous rhythm monitor that can be placed underneath the skin. On the same day a patient comes in, we will, it's almost like a microchip for a pet, and they go home with a modem, and that modem is connected directly to their physician, and that device is continuously picking up their rhythm. And so if they have any rhythm abnormalities, their doctor will be aware of it within hours.
So is that a diagnostic tool for things that happen irregularly?
That's a diagnostic tool that can be used for patients who have known atrial fibrillation to determine whether their burden is enough that they would require a blood thinner, or to determine whether therapies we're utilizing are working, and also patients who have been diagnosed with a stroke and they're unsure of the cause. We can use that to ensure that they don't have underlying atrial fibrillation as the cause of their stroke, or for patients who pass out to ensure that there's no arrhythmia as a cause for passing out. Another technology that's very new and exciting is a leadless pacemaker. So a pacemaker that does not have any leads. There's no external generator under the skin, and there are no leads that go into the heart. It's this tiny device about the size of a nickel that we can implant directly into the heart, again from the veins in the leg, and it serves to treat patients who are chronically in atrial fibrillation and just need the lower chamber of the heart to be paced, and it's a way for them to to be treated without having any type of surgical procedure or generator. So very promising from that perspective.
You know, you've done a great job of telling us what you do and why. People want to know their doctors too.
Sure.
So if I could ask, what do you find the most rewarding aspect of this specialty?
So I think it's very rare to be in a specialty where a patient will come to you with significant morbidity, that they are struggling with their quality of life, and you can bring them in for a procedure that they will leave the same day and be cured. And they'll come to your office 2 weeks later and say, my life is totally changed. It's rare in the medical field to say that we have cures, and my specialty provides us with the tools for that. And as I was stressing before, there are so many modalities and there's so many new technologies that patients who don't need to suffer for long anymore. If they come even in advanced stages of disease, we can always help them.
So what advice do you have for people who are maybe listening and watching who have arrhythmia?
So arrhythmias, again, are treatable. It's a matter of being educated. It's a matter of making good lifestyle choices beyond just listening to what your doctor tells you or what they do to you, whether it be with medications or a procedure. It's about what you do with your life. So typical heart healthy advice: eat right, exercise, avoid stimulants, avoid alcohol, and understand that treating an arrhythmia is a partnership. It's a partnership with your physician, whether that be your primary care doctor, your cardiologist, or your electrophysiologist, to have that partnership.
On the hierarchy of lifestyle choices, what are some of the other issues that play a role? Does stress play a role in this, for example?
Stress can definitely trigger an arrhythmia, but you have to have the underlying substrate for it. So you have to have either, for atrial fibrillation, the triggers that you were born with, or the underlying heart disease that will, from high blood pressure, obstructive sleep apnea. And stress in those situations, yes, can trigger the arrhythmia. So again, it's important to try to stay away from those triggers. Again, some arrhythmias are more on a management type of strategy rather than a cure. Atrial fibrillation is one of those arrhythmias that we can't say definitively that we have a cure for it, but we are able to manage it extremely well.
Well, we certainly don't want people to start self-diagnosis, but we do want to give people some guidelines. So just a couple of general questions. Is there a gender difference?
Arrhythmia is almost 50-50 in terms of gender prevalence. Atrial fibrillation probably affects a slightly increased predominance with men, just because of the associated risk factors are more common in men: high blood pressure, sleep apnea. But other arrhythmia, especially bradycardia, is just as we get older, the intrinsic conduction of the heart starts to deteriorate, and so kind of 50-50 between patients. And then genetic causes for arrhythmia, or those supraventricular tachycardias that are curable, are pretty much also equally distributed amongst the genders.
And finally, and we just have a few seconds, is there like a magic age where it really becomes noticeable? Tri-City Med?
It all depends on the arrhythmia. I think the ones that, again, that are curable, the SVTs that are one area, that can be presented at any age. Atrial fibrillation commonly is more common as we get older, but we do see it in increasingly younger patients in their 30s and 40s because our diagnostic tools are better. And then those slow heart rhythms are typically only an issue in the elderly.
Dr. Cohen, thanks for great information. I know we've done some good today.
Thank you.
And thank you for watching. If you want further information on electrophysiology at Tri-City Medical Center, please visit tricitymed.org. Thanks for joining us on another episode of What's Happening at Tri-City Medical Center. To watch this or previous episodes, visit our video on demand page at KOCT.org. We'll see you next time.